for helping us to host our very first webinar. Everybody, and I wonder how you are. Are you as excited as I am? We are able to celebrate MS Day 2020 in lockdown, and we are celebrating what connects us rather than what divides us. That, I believe, is the ethos of being together. So I think it's wonderful to have a neurologist and other speakers to join us. Dr. Opperman, who we all know, speaking to us in a collective of MSs. Normally, he can only speak to a select little group in a room, but today we can share him with hundreds of people out there. I think it's really powerful. And in the words of Kate Shepard, all that separates, whether it's a race, class, creed, or sex, is inhuman and must be overcome. So the power of this collective here today is more than just the webinar itself, but it's the stories behind all of us. And when you get to know the stories in this collective, you get to know the person behind it. And that is what we are talking about in terms of coming together to really engage and talk in spite of lockdown. Because when MSs get the right tools and knowledge to understand and manage the disease, they can create a better environment, not only for themselves, but for everyone around them. So it is my great pleasure to welcome everybody on the call and wish you a valuable hour in the presence of our valued and respected speakers. Particularly proud of the MSs who managed to get a grip on this new technology. More than, I think it's 250 people have registered, right, Kelly? So Kelly had to open up a room with more capacity as this was an unexpected and unprecedented response. So let us get down to business. For the next 60 minutes, this is what we're going to do. Introduce our speakers one by one, starting with Dr. Dion Opperman. Then it will be followed by a question and answer session. Next up will be Kelly du Plessis, the CEO of RARE, with her question and answer session. And last speaker will be Dr. Helen Malherbe, who is an epidemiologist, and she's going to have a question and answer session as well. So Dr. Opperman will be speaking about treatment and access to treatment, when and why to switch treatment, taking care of yourself during and after COVID-19, and lastly, touching on the importance of connections in MS support groups. So let's get started. Dr. Opperman is an expert neurologist practicing in Cape Town with special interest in multiple sclerosis. He is, among other, one of the co-authors of the published guidelines for the treatment of multiple sclerosis in South African context. The MSs in South Africa love him dearly for his compassionate sharing of information with us for the past very many years, for his availability to answer our burning questions and his honest approach to more controversial treatments out there. Dr. Opperman, we are excited to start off our kickoff webinar for multiple sclerosis South Africa with you, and thank you so much for being available to share your knowledge and wisdom with us. Welcome.
Thank you, Nan. It's a great pleasure. And just either of the ladies that are monitoring this, I tend to speak rather fast, so shake your hand up in the air if I'm going too quickly. What I thought I'd do is, first of all, say, I know it's not the right color orange, but it's the closest I have to orange for today. In South Africa, we follow a very specific approach to the treatment of MS, which isn't necessarily the standard approach. There are two ways of approaching the treatment in relapsing remitting multiple sclerosis. There's the tiered approach, and then there's the more aggressive approach. So if you go to any big MS meeting internationally, they will talk about these two options. Whether you start slow with safe drugs and slowly upgrade as you fail, or whether you go aggressively all out from the beginning. At the moment, things might be different, but there are huge issues around this and huge debate. So in other words, do we start someone on a simple drug that doesn't have very many side effects, that might be slightly less effective? Or do we say this is a horrible disease, it's going to cause all kinds of problems, and right from the beginning, we're aggressive and we try to stop the disease as quickly as possible? And there's pros and cons for both. If we start in the tiered approach, you start with low-risk drugs that have very few long-term side effects that are well tolerated. On the other hand, if we start with aggressive approaches, we have the potential to possibly cure MS, but at greater risk. Immediate risks as well as long-term risks. In South Africa, we don't have a lot of choice. We simply have to follow the tiered approach. There are exceptions for those patients who are very aggressive right from the beginning of their course. In other words, someone who's diagnosed and relapses very rapidly, we can often get to tier 2. At the moment, our tier 1 drugs are the interferons, Copaxone, and Aubagio. Those are our tier 1 drugs. And there are 4 different interferons we have available. These are, if you're on most South African medical aids, it's relatively easily accessible as long as you have fulfilled the correct criteria for the diagnosis of multiple sclerosis. In other words, your MRI, your clinical findings, as well as your lumbar puncture need to coincide with the diagnosis. There are lots of other drugs available in the rest of the world, not necessarily available here right now. So we follow this tiered approach. The access to treatment in state, it depends from province to province, what you will be eligible for and how they will treat you. There are certainly interferons available in some of the state care for patients. At the moment, we in private practice are mainly following the tiered approach as we have very little choice. And in fairness, the question non-brought with coronavirus, we know that some of the drugs are slightly riskier and some of the drugs are really quite safe. And that's what you need to understand. By quite safe, we're saying we assume they're safe, and by risky, we're saying we assume they're risky. We have no strong evidence about this. The next question I get asked a lot around the coronavirus at the moment is, what are the risks to people with MS? Let's take the drugs out of the equation to start off with. The risk of someone with MS being slightly riskier to develop complications if they contract coronavirus in South Africa probably relate onto how disabled they are. Someone who is up and about in the workforce is probably less risky because they are healthier in general. Someone who is disabled, who has difficulty moving, has higher risks. Same as getting the flu, getting all the regular things. The less mobile, the less you're able to get around, the higher your risks are of developing complications. As far as the drugs are concerned, I've recently reviewed a lot of articles, and there's a really nice article available from Dr. Giovannoni from London, which you should well worth looking at. It's very simply put at, and he simply says that most of our first level drugs, specifically all the interferons, and in South Africa that includes betaferon, Rebif, Avonex, and Plegridy, as well as Copaxone, are extremely low risk, whereas Aubagio falls under the same category according to them. It seems our second tier drugs, they also seem to think are relatively low risk, in other words, not a big problem, and that would be the patients on Tysabri at the moment, as well as those patients taking, which we call Tuvigen in this country, fingolimod, are probably in a safe situation. It seems at the moment that the only really risky problems are going to occur with hematopoietic stem cell transplants, as well as those patients who need to get alemtuzumab, which is available on Section 21, in other words, special application here. those seem to be the riskier patients because of the immunosuppression, particularly an issue right now. So that would be really the risks around that. I'm going to spend a little time talking about accessibility. Accessibility to treatment is tricky. We're in a very unfortunate situation in that it depends where you're insured, how you're insured, what you can get. We have the disease listed as a chronic prescribed minimum benefit, but it is tricky as each of the insurers interprets this slightly differently. And sadly, each of the provinces that does treat MS interprets it slightly differently. We know the Western Cape has a problem with the treatment of MS in the state. I'll say no more about that. That I leave up to Non and her group to take forward for us, hopefully. And maybe Kelly can get involved there. That would be quite fun, I think. Lastly, the importance of being around other people with MS. You know, I think the importance is you need a positive force of people. People who are going to be negative all the time is going to bring you down. But if you can be around people who are in the same situation as you are, or similar, or in fact completely different, but have the same problem, you can discuss what your feelings are and how to process the situation. Also, once you're in that situation, you'll know that there are other paramedical things one needs: speech therapists, psychologists, occupational therapists. There's a whole collection of various alternative as well as standardized extra medical care you'll need. And if you can belong to a group that understands your disease and can find someone in that fraternity who understands how to treat people with MS, there's no point going to someone who has no understanding of MS, who fatigues you out at the end of a physiotherapy session, for example. Whereas someone who understands MS will certainly help you. The next thing is the fellowship of being around other people with MS. It certainly helps. I'm not saying you have to go to every single meeting, but belonging to and giving word to a group that then can act on your behalf for the future and treatment of this condition. I'd like to spend maybe a little time talking about the trickiness of managing your symptoms. At the moment, things are a little difficult here. We're all feeling isolated. And to actually get your treatment care at the moment, you need to be proactive. Don't stay back and say, I'm too scared to go out, I'm too scared to see the doctor right now. I think it is fairly important for you to still be aware of what's going on and carry on as though this was a normal, relatively normal time. I'm not saying exposing yourself, I'm saying your contact with your neurologist and your other medical care. If you are on one of the drugs that you need regular infusions, for goodness sake, don't stop this because you're too scared to go to hospital. Our Tysabri patients need to come in regularly. This is important. The screening process at all our hospitals seems to be extremely good, and I think this makes a huge difference. As far as future treatments are concerned and alternative treatments, Don and I chat a lot about this. I do think there are excellent controlled clinical trials on all the treatments we have available in South Africa. And I do try to encourage my patients to be very careful of some of these fly-by-night therapies that you read about, that you see sometimes in the popular press. Be very careful. We've seen these go past over the years. How many people read about and were enthusiastic about these shunts for the venous flow? We know that wasn't real. When I first started in this business, people were going and having bee stings, being stung daily by bees. There are lots of these issues that one really should be very careful about and discuss it. Be honest. I mean, most of us neurologists are fairly open people. If you have an idea, discuss it with us. It might be relatively harmful and cause no problems, but it might in fact be detrimental to your health. We know even in clinical trials of good drugs for various disease entities, sometimes these trials are stopped because the outcome is negative in the end of the day. In other words, it doesn't just not work, but makes things worse in the end of the day. So please Be open with us. Come and discuss these things. Don't just go off and try some strange treatment. There are lots of these things that go around, but we have some really good treatments and the prices have come down. It has become more accessible to all. I'm a minute or two early, but I'm going to let Non take over with the questions now if she'd like to.
Non, you're still muted.
Unmute. There you go. Thank you. Yes, that was very informative. I think we can now move over to the questions section. Kelly, would you like to?
Sure, I can handle that. So, Dr. Opperman, the first question that has been raised was, I'm a newly diagnosed MS patient. Are they more likely to contract the COVID virus? I think this is probably going to come up a few times given the scenario that we're in currently. So I'm not sure if you can answer that.
It's a very difficult question to answer. If you look at the questions I've been getting, a lot of workforce have listed reasons for someone to work at home, including autoimmune disease as a generalization. I don't know that we know the answer, but I would suspect that someone who's in general good health is less likely for this to be a problem. But we can't, I don't think anyone can give you a definitive answer. My feeling would be that as someone with an autoimmune disease, you have altered immunity, you should probably be a little bit more careful. But I don't think you're a huge risk like someone with asthma, someone with chronic lung disease, someone who's older. I think you're probably slightly above risk, but I don't think particularly.
Okay, I think that answers the second question as well with regards to, is MS considered a comorbidity? Obviously a concern for people who are working in high traffic areas like schools, etc. We're seeing this across the rare disease community. And I think, as Dr. Opperman says, obviously be cautious, rather be cautious than not. And if you have the opportunity to make alternative arrangements, do so. Specifically on the school question, Claudia, I can tell you for sure that I know that there has been certain documentation circulated by the Department of Education that I'd be happy to share with you in this regard. You do have the option to take it up with the department or your human resource center, your principal, dependent on obviously if it's a private or public school, and they have granted concessions in this regard for teachers where possible. So I'd be happy to share that document with you. There is another question from Helga. There are so many diets such as paleo, Terry Walls, Banting, Mediterranean, that come up as suggestions for people with MS. Are there any types of food or diets that you could recommend? Other than vitamin D3, are there any other supplements that people should be using with MS or avoiding?
Come up with the question, I think that's the easiest. If you're vitamin D deficient, you should be supplemented. I would suggest check your vitamin D levels first before you just simply supplement. The rest of the other supplements there's no scientific evidence that anything is of huge benefit. I personally believe one should probably be on some form of antioxidant. I don't think it really matters which one. Diet-wise, there's lots written about diet from, as Helga quite correctly mentions. I'm not convinced there's any one diet that is hugely important for any patient. I do think that we would probably best eat as healthy and as organic and as unmodified as possible. In other words, the healthier diet where there's less pesticides, less genetically modified products, and as less processed food especially. I think that would make the most sense. So the healthier the diet, the better. I'm not convinced there's any one particular diet that makes a huge difference.
Okay. Sorry, I'm just reading through them. Is Copaxone any closer to being available in tablet form, to your knowledge?
No, not to my knowledge. In South Africa, we still only have it available as a daily injection. I'm hoping we're going to get the 3 times a week injection available, but at this point, that's where we're stuck, and I don't know that we're going to be getting it anytime soon.
Okay, what is the most aggressive MS treatment available in South Africa?
So at the moment, what the most aggressive treatment that we can easily get hold of would be Tysabri, natalizumab infusions on a monthly basis. However, with Section 21, in other words, if we did special applications to the medical aid, one can apply for both cladribine and alemtuzumab. Now, cladribine and alemtuzumab, for those of you who don't know, I kind of like to refer them as bone marrow restarters. What they do is they kind of knock out your B and T cells, and then your B and T cells grow back slowly in different ways. Some slightly better than others, but there are kind of disadvantages and advantages over the other. So all 3 of those are available, and in special circumstances, one can do hematopoietic stem cell replacement. So we have 4 fairly aggressive treatments available here.
Okay. In terms of, someone has said that they were diagnosed just before lockdown. Their neurologist opted to hold off treatment to protect their immune system during this time. Obviously, there's a concern that it would have a negative long-term impact. I think my direct response to that, because we've seen this deferment of patients across the board, and it's infuriating to say the least, because there's no clear indication as to when over it or when we through it will be. So I think that from my perspective, we've seen a lot of patients, and that has always been my first question. There needs to be clarity on how long the delay is going to be, and it can't be indefinite, surely. But Doc, I'm not sure if you have anything on that.
Look, maybe I have a very specific opinion, and not everybody has the same opinion as me. I think MS is a terrible disease if it's not addressed abruptly. If one can, and there are certainly some of the treatment options that are minimal risk, which you can discuss with your patients. There are some that are clearly riskier, that one would be careful. So the question that I didn't address earlier, that I'm going to quickly address now, is switching treatment. If you're on a treatment and you're stable right now, and you want to switch for side effects, I think you're crazy. In fact, switching for side effects has to be very carefully thought out if a drug is working. But if you're on a treatment and you're failing, and your disability score is going up, and you're having lots of lesions, you have to weigh up the risks of changing to a riskier treatment with coronavirus versus the fact that your MS is going to get into trouble. And I do think one has to look at MS as a seriously important disease which can cause huge disability in the future. So I think one must weigh up the pros and cons. One must not be too conservative, but also not too aggressive right now. So I'm kind of staying in the middle of the way. You take your patients one by one, and if we need to upscale and go aggressive because you're going to end up more and more disabled, and we're going to miss the boat of opportunity to treat the inflammatory phase, then one has to go ahead.
All right, another interesting question that has come up. Someone says that they do a brisk walk 20 kilometers per day. They've had mild MS since 2018. Are they overstretching themselves?
I think that's a very easy answer. I think every patient is going to be different, and I have MS patients that do marathons. I have MS patients that swim long distances. We all know that you're all different. If your body is tolerating good, healthy exercise, it can only be beneficial for you. If your body can only tolerate to walk around the block once and you fatigue, that's also good for you. Do what you can tolerate. But if you're able to do good exercise, go ahead and do it. Obviously, don't go to extremes where you're going to influence your immune system.
Okay, and is there anything specific that can be done to improve bladder control?
Lots. Bladder control is I think, one of the most important things that's underrated. There's basic things that your neurologist can start with, and we often give certain drugs, certain exercises. If you mainly have problems at night, avoiding excessive fluids at night, But when that becomes an issue, one needs to get involved with a urologist or a urogynecologist that has an interest in continence. There are huge options, from stimulators to Botox in the bladder to various drugs, and in extreme cases, even a urostomy. In other words, when you get to a point, there are lots of options. So you do not have to live incontinent. It's not necessary. Very importantly, I'm going to digress slightly because I think it's important. One of our biggest problems with our MS patient is recurrent urinary tract infections, which mimic relapses. In fact, quite often that's what we look for first when we think someone's having a relapse. So bladder hygiene, and I don't mean you're unhygienic, I mean hygiene, making sure your urination is complete and regular is vitally important. If that's not being addressed completely, see a urologist in the field.
Okay, and then I think, so there's been a ton of questions that have come through, but I think a lot of them might be addressed in mine and Helen's presentation as well. This one, I'm on a fingolimod. My neurologist mentioned that I would have to stop treatment when getting pregnant, but when stopping, your MS worsens. Will stopping treatment for 9 months worsen my MS long term?
So, the whole question of pregnancy and MS is a huge one. There's various debates, and I think you need a good relationship with your neurologist to decide whether you're going to fall pregnant, when you're going to fall pregnant. And I think for those of you that are online that are newly diagnosed, I think this is something that unfortunately you need to think of upfront. In fact, when I newly diagnose a young lady, I often have a family discussion right from the beginning as to when they want to start their family, and we choose the drug at that point. So that's the one thing. Yes, fingolimod you have to stop, Obagio you have to stop. There's lots of drugs that you have to stop because they are potentially risky. When we stop any drug, there's a chance of having a worse outcome, in other words, having a bad relapse. But particularly with those drugs that hide the active immune cells, and those are fingolimod and Tysabri. Those drugs are associated with a relapse when you stop them, even if we have to stop them, because we're upgrading to a more aggressive treatment. So those are drugs that are very tricky to stop. And one has to think about whether you would want to switch to an alternative to cover you during pregnancy. We know that there are certainly at least 3 of the drugs that are probably safe to fall pregnant on.
Okay, so I'm going to limit it to 2 more questions, just in the interest of time. The one is that someone on interferon treatment has had a severe burning sensation on their upper left thigh, came and went for 2 days. Is this a flare-up or signs of a relapse?
So that's a difficult question. A very focal burning area, probably not a relapse, but it very well could be. The most common reason for a burning sensation on your upper thigh is something called meralgia paresthetica, M-E-R-A-L-G-I-A, paresthetica. Google it. It's often where your tummy catches the nerve on the upper thigh, or when you've been lying in bed for long periods of time. So one would have to have a look at it in the distribution. If it's only on the outside, it's very unlikely to be an MS relapse, but that's not impossible. You get weird MS relapses.
Okay, and then the very last question, which is generally controversial, but I think on the minds and hearts of a lot of people, is with regards to the use of cannabis. Is this something that you see within practice? Is it something that you are averse to? Is it, is there, I don't want to say is it recommended, but, I think one of the concerns that we have from a patient advocacy organization is that of transparency. We know that patients that have chronic conditions often will experiment with these drugs. And our thing is often, always for them to be open and honest about that experimental use with their doctors so that they're aware of it. But I'm not sure if you have any specific opinions with regards to cannabis.
So let's start off that there is a cannabis product that is registered in the United Kingdom and parts of treatment for symptomatic treatment of some issues with MS. So there is an inhaler that is commercially available. So there's no doubt that cannabis assists certain issues with MS. It seems to help with some degree of bladder control, and it certainly helps with some degree of spasticity. Those drugs are commercially available. The problem in South Africa at the moment is the legislation is complicated, and the products patients are buying legally should have tiny amounts of cannabinoids in, and the other products, who knows what you're getting. So that's the issue right now. We don't know how much you're getting, what you're getting. Once quality control gets involved, I think it makes a big difference. I certainly do think cannabinoids have a place in the treatment of MS. And if you in fact read our guidelines that we published in the South African Medical Journal, it is mentioned that cannabinoids have function in both bladder control and spasticity. So that is written down. Very important. You must discuss with your neurologist all the drugs you're taking, because natural products can have interactions. I think it's vitally important.
Absolutely. All right. Thank you so much, Dr. Opperman. Non, back to you.
Thank you very much. That was really informing, and I'm great. Thank you for handling the questions. Dr. Opperman, is there anything else you would like to add before we introduce the next speaker?
I think just lastly to reiterate, you need to belong to a community of people, because sometimes you're going to be frustrated. You're not always going to get your answer from your neurologist. Belong to a society. If you're foreign speaking and you don't speak English, I happen to recently have met someone who's Spanish speaking. Belong to a society that speaks your language. It's vitally important to be a group of people, and very importantly, as patients, you need to be informed. Thank you, Noah.
Thank you very much. We really appreciate your time and your effort. Bye-bye, doctor. Would you like to
I'll be
stay
available
now?
for questions at the end if there are any. Thanks.
Thank you. Thank you very much. Okay. Okay, guys, so we are going to go ahead with introducing our next speaker, which is Kelly du Plessis, wife, mother, 2 children. She's the CEO and founder of Rare Diseases South Africa. Rare Diseases was born out of a necessity when Kelly's oldest child was diagnosed with Pompe disease at 11 months. At the time, treatment for this rare condition was not available in Africa, so Kelly's personal journey of patient advocacy started there. Kelly serves on various boards and committees which focus on improving quality of life for rare patients. And in 6 years, Kelly has taken rare disease policy and patient advocacy to new heights in South Africa, ensuring that the patient's voice is never forgotten. Kelly, we're very well aware of your busy time schedule and how much your workload has increased during the time of COVID-19. And for that reason, we are totally grateful and appreciative of your time and sharing your knowledge and wisdom with us today. Please be welcome in your own hosting webinar.
Shame, thank you very much, Non. Firstly, I just want to say a big thank you to the MS Society for all it's doing. I think that you guys are making really significant impact, and it really helps to be able to work alongside organizations that are so patient focused, because it allows us to focus on some of the global issues being by advocacy, etc. I'm going to start my video because I forgot that it was off. So essentially speaking, I was going to discuss, sort of the role of support groups in chronic illness today, but I think some of the questions that have come up are probably a lot more of a burning issue. So I think one of the things that needs to be addressed is the issue around funding and the lack of funding sometimes, and what we have tried to do from our side. I think so obviously funding is complicated in the South African space. And for those of you who are not aware that even on a private medical aid, your benefits always seem to tie back to what is available in state. So whilst our turnaround times and our hospitals might be slightly more comfortable with a nicer view, in terms of the quality of care and the medication that you get, often it doesn't differentiate much from what is available in the state sector and what has been published in guidelines, etc. I know that there has been numerous issues on the Tysabri front. I know that we had lots of patients who were battling to have access their treatment at the end of last year with Discovery, and we've subsequently had a few patients on other schemes as of this year who have had problems. And I also know that there's been a reduction in the support that's been offered from the AICF. So I thought maybe I would just try, provide some clarity as to what we can and can't do as an organization, and also how you can be better empowered really to advocate for yourself with your medical schemes, etc. So obviously there's various tiers of medical treatments. You've got your level 1s, tier 1, tier 2, tier 3 treatments. They are differently priced a lot of the time. Some drugs are more expensive than others, and I mean, that is just the way it is. So from a application perspective, when applying to your medical aid, ensuring that you've got all the documents in place at the beginning of that request is absolutely crucial. Alternatively, what happens is you get issued a reference number for the first email that gets sent, and you get probably another 4 or 5 emails with another 5 reference numbers for every subsequent document that you send, which makes tracking and tracing very, very difficult on the scheme side. So if you are waiting for further motivations to be done, or you're waiting for baseline assessments, or you haven't got your neurology, your MRI report, etc. yet, rather don't rush that application process. Rather wait until you've got everything together before making that submission, because that really helps. When you submit a comprehensive file from the first time, that really makes a difference. The second thing is to always make sure that you've got an extensive clinical motivation. So unfortunately, not that I think it's necessarily fair, but the clinical outcome and the decision of the schemes is often based on how your specific situation's been motivated for. So a patient who sends an extensive motivation with all the supporting documents will stand a much higher chance than a patient who has a 3 sort of lined motivation. So it's important to make sure that you get as comprehensive of a motivation to begin with. I know it is tough and it takes up a lot of the doctor's time to write up these motivations, but it is essential. Medical aids always look at treatment from an outcomes perspective. So it's for them to have a clear understanding, particularly where you are deviating from drugs or switching between one drug to another. There's always this real need from a medical aids perspective to understand the rationale and the decision making behind that. So to simply say, my doctor, to submit a script that says, my doctor says that I now need to change this medication with no associated information isn't really helpful from a scheme's perspective. So we always say, make sure that your motivation includes very real reasoning as to what you are expecting from the changes, why you have made the decision to change treatments, what the clinical basis is for that. And, we've just had a case come through Council for Medical Schemes for the very first time, which took the patient's social circumstances into account. So this particular patient was a school-going child who required a treatment, and what the medical aid was offering was a IV treatment, which required recurrent hospitalizations. And this particular doctor had motivated for this patient to get subcutaneous injections, which is an alternative treatment that is more expensive. But the argument was placed and was put forward in the Council for Medical Schemes discussion when it was sent through for complaints. And the Council for Medical Schemes actually ruled in the patient's favor on the basis that they said they could understand that being a school-going child, not necessarily going into hospital all the time versus, the cost and the associated anxiety and loss of time and impact of that was not in the best interest of the patient, and therefore the alternative treatment that had been proposed was the better option. So as an example, if for instance, if you are having to motivate over a treatment that requires recurrent hospitalization versus something that can be done at home, and you are in a position where you're living 65 kilometers from the nearest hospital, etc., etc., include those sort of social circumstances in the motivation as well, because realistically, medicine doesn't treat diseases, they treat people. And it needs to be remembered that, you know, we need to have a patient-centric focus. So that's always critically important. With regards to a lot of the issues that are faced, I mean, I saw a question come through with regards to someone saying that there might be a stock shortage of a particular product. As an organization, we know, and particularly now during this COVID time with the limitation of flights and commercial services, etc., in terms of logistics, has made it very difficult. So to get access to treatment all around. So we know that there have been some stock shortages. If you are experiencing something like that, please make sure that you actually register that on our website on the stockouts page, which is rarediseases.co.za/stockouts. And by doing that, you will have to complete a form. But by doing that, we can then collectively take that discussion up with the distributors and the manufacturers, etc., to try to determine how long, what the delay is, etc., so that we can provide accurate feedback. So that's normally not something, normally your pharmacist, etc., will report those stockouts. But during this time when healthcare systems are so under-resourced and strained, we've realized, so we've tried to put the power in the patient's hands to be able to report those sorts of issues. So if you're having those sorts of problems, please don't hesitate to reach out. There was also another question that I'm just trying to find that had come through. If you can just give me one sec. All right, so I can't find it now, but I'm sure it'll crop up at some point. The other thing is with regards to, you know, just engaging, and I reiterate what Dr. Opperman was saying with regards to being part of a community. I had a discussion yesterday with a company who's trying to develop a framework for patient organization groups. You know, 30, 40 years ago, when patient organization groups came about, patients joined those groups to access information. Information was probably the most valuable thing that a patient organization could provide to a patient all those years ago. Now, with times having changed, patient organizations have been replaced by Google. We don't connect with one another simply to get access to information, because there's numerous ways to be able to do that. But what has also changed is how we interact with each other. The world is a very, very busy place. I think we've lost, during this lockdown, I think we've actually realized the values that we've lost over the years because we have become so busy. So the importance of having people and communicating and conversing with people who understand what you're going through on a daily basis, who can, you know, literally pick you up when you're really down, who can provide you with practical support, is absolutely invaluable. And I think from a patient organization perspective, it's very, very difficult for patient organizations to remain committed and motivated when we feel that the patients are not necessarily participating, and you know, really there's not much of a willingness from their side to contribute. So we all, as patient groups and organizations, have various things that we, you know, it's two ways. We want to be able to provide the community platform, etc., for patients to be able to connect, but we're also wanting to be able to understand, you know, what is happening from a patient perspective, you know, in your homes, in your daily lives, so that we can advocate better for those situations. And if we're not aware of them, then we don't know to advocate for them. So communication is critically important. So I suppose I just wanted to say that, you know, support your groups. The groups that you're a part of are really, really doing their absolute best in trying times to, you know, to provide you with the things that we feel that you need. If we're not providing you with something that you feel that you are in desperate need of, let us know so that we know that we need to change our focus. And we've got to adapt just like the world has to, is particularly during these times. So we need to find new and innovative ways to do things differently. This, I think, is a first. Having a webinar such as this has provided people from around the world the opportunity. I saw someone was joining on from Mauritius earlier. From around the world, the opportunity to be able to connect and, you know, have a shared platform. So we're trying to be innovative where we can. Let us know what we need to do better. Really use us where we can, where we are available to assist. Use us, make use of us, get involved in the efforts and initiatives that we take, and hopefully together we can have a much stronger community for all of our patients. So yeah, that's it from me. Non, I'm not sure if you want to add anything.
Kelly, that was great and very informative. Thank you. As usual, you speak from the heart, and you've got such a good knowledge of what you're doing every single day. So I'm quite proud of that. I think there must be some questions coming up. I'm not sure. I can't. Can you see any questions on your side?
Yes, I can. I can see quite a few of them, but maybe I can suggest that Helen starts and I will then go through them and sort out the question inbox, and then we can take combined questions after Helen's done.
That's brilliant. Okay. So if Helen can, hi Helen. I can see you. Can I hear you?
Yes, you should be able to hear me now.
There you go. Good. Thank you very much. It's my great pleasure to introduce Dr. Helen Bladder. Helen is a post research scholar at the University of KZN, UKZN, and also assists, I'm still here, and also assists with research in an honorary capacity at Rare Diseases South Africa. Helen's involvement in the congenital disorder and rare disease community began way back in 2004 when she lost her first child to trisomy 18, which is Edwards syndrome. Soon after, established a contact point for families in South Africa affected by the same condition. Helen is an active member of several key national and international technical working groups, advocacy committees on human genetics and congenital disorders. Helen, we are very proud to be in association with you and the knowledge you bring to the table. Thank you for honoring us today in this first ever worldwide virtual MS Day celebration. Welcome, Helen.
Hi, good morning, everybody. Thank you very much, Non, for the introduction. Despite being adept at using Zoom every day, I'm struggling to share my screen. Can you let me know your side, what you're seeing at the moment?
It is working, Helen. We can see your opening slide.
Okay, great. Thank you very much, Kelly. Good morning, everybody, and thanks for this opportunity just to share a few minutes on just an overview of multiple sclerosis in South Africa. As explained, what I'm going to do is just give a few basic slides. I've just got a few slides because I just find that in a webinar situation, sometimes it just helps to have a few things to focus on as the speaker explains it a little bit more. So what I'm going to do is just give an overview of what the situation is in South Africa, because we've been talking about the disease itself, we've been talking about support groups, but what's really needed in order to improve state services and the services available in South Africa is data. The scale of the problem and the size of the problem. And until we know what the size of the problem is, we don't have the scale of that problem so that we can actually start to really influence the government and leverage them and say, this is what we have, this is the size of the problem, this is the number of people that are affected, and we need services that are in place to actually be there for those people. So the first slide I've got up now is a map of the world. And this is taken from something called the Global Burden of Disease. And this is a global research group. Basically what they do is for countries in the world where there aren't any data, they use estimates to actually give a best estimate of what they think the numbers would be for countries where there aren't any data. And if you basically look at the colors, and it goes from cold to hot, essentially, with coldest colors a very dark blue, as you can see for most of Africa. That shows where there would be the lowest prevalence, the lowest number of people in the population that are affected by MS, going right up to that red right at the top for Greenland, with the highest prevalence or the number in the population that are affected by MS. So this was a paper back in 2019 by the Global Burden of Disease based on estimates. And there's almost, you can see like a blue stripe going across the world, where it shows that there's, according to the latitude and where you are geographically, they suggested that there might be less people affected. But if you actually look at this closer, and you look at most of those countries that are in that band where they don't think there's many people that are affected or there's a low prevalence, you can actually see that most of those countries are actually middle or low income countries or developing countries, and that those where there's supposedly more people affected by MS are high income countries. So where there's more money spent on capacity building for health researchers, there's better diagnostics, there's better care and so on, and there's better access to diagnostics and care. So there's a much higher likelihood of patients being diagnosed. So it just makes much more sense. So what do we actually know about multiple sclerosis in South Africa? Well, in actual fact, it's very little. And just globally, we know that it's a combination of genetics, environment, and lifestyle. So it's one of those conditions where we don't exactly know what causes it. There are some genes involved in the degree of the progression of the disease and the speed of the progression, and there's environmental factors and there's lifestyle factors, but how it actually happens specifically is still a work in progress. In Africa and South Africa specifically, as we saw in the map, there's been there's a big black hole in terms of research and data. And in South Africa specifically, there were about 3 or 4 or 5 papers in the 1960s and 1970s and so on. But there was then nothing until around 2007 of some work done in KZN that actually really looked at the whole population and not just at the white population. And what's interesting is that it's always been thought there's been a much lower prevalence in South Africa and Africa, but they actually think now that it might be an underestimation due to the, sorry, apologies for the typo, but a lack of clinical expertise and exposure to the disease, and limited access to advanced medical resources, including MRI, of course, for diagnosis. Lack of access to tertiary services, so that's where you're referred to, expert specialists, neurologists, and so on. The lack of reimbursement and affordable care, as we well know in South Africa, with only 15 to 16% of the population able to access private care. And then competing health priorities in a resource scarce environment. We know that HIV and TB, and at the moment COVID, is resulting in a lot of the available resources, whether financial or medical health workers, being diverted to these other priorities. But the one thing that we do know for sure is that the incidence and the prevalence, so what that means is the number of cases that are being identified and added to those that are affected by multiple sclerosis are increasing. If we look at these graphs, if we look from 1990 going towards 2015, there is a clear increase in the numbers. Now, this could be for a combination of reasons. There could be an increase in the prevalence. It could be changing migration patterns, people moving from place to place, moving from rural areas to urban areas. We know that the urbanization is clearly happening in South Africa. The economy is growing. Diagnostic technology available has improved over the last 20 years. Other diseases that are highly prevalent are being managed better. So people are being, those diseases are being dealt with. And so as a result, they're surviving, and they may well be also diagnosed with MS, and the ability to diagnose those with MS as well is improving. And also access to care, the expertise, and the availability of diagnostics is actually improving. And research is starting to be undertaken with this research study undertaken in 2007 in KZN, and some more recent work in 2020. And of course, there's lots of unknown reasons as to why it might be increasing. So in this slide, which is coming to the end now, what I've literally done is just dropped a few numbers for the different race groups in South Africa. Because what's really interesting about multiple sclerosis is there isn't one population prevalence in South Africa across the board. We know for a fact that multiple sclerosis has got a much higher population prevalence in whites. And what's interesting is if you look at that prevalence of 1 in 3, just over 3 or just under 4,000 people, and compare that to the rarity that it's seen in blacks, which is 1 in 454,000. It's a huge range. So overall, South Africa is actually documented as being a medium prevalence country for multiple sclerosis because of that range, that difference between the whites in the population and the blacks in the population. And in between that, you've got mixed ancestry and you've got Indians. So it's very interesting. And this is adapted from that study done in 2007. And this is a very crude number, and I wasn't confident enough of the numbers to put in actual numbers to say how many people in the population are affected, because the study actually only includes over 15, the age of 15, because of the age range for diagnosis between age 15 to 75, and of course the mean age of diagnosis at 33. So this is very rough and ready numbers because we don't have any data, but it would be very interesting to compare numbers with the number of registered patients at the MS Society of South Africa, and also just to some food for thought that I want to put out there is the reason that we need data, and we need data because without it we cannot leverage with the government. And as Kelly has emphasized, is that everything, even in the private sector, gets compared with state services. So the number one priority that we need data for is to leverage and motivate for improved services in the state sector. And that will improve it across the board. And going forward into the National Health Initiative, we need to ensure that as they develop their whole framework for the packages of care and packages of services within NHI, we need to ensure that the relevant services for MS are included and incorporated into NHI. So, and we need data to be able to justify, because as an evidence-based health system in South Africa, nothing will be done if we don't have the numbers and we don't have the costs for the services that are needed. So that's why we need data. Yeah. Thanks very much. And I think that's me done.
Thank you. I was listening. That is very, very interesting. And I think we needed this talk of yours with statistics and data for many years already. I'm so glad that we discovered your knowledge. Thank you, Helen. That was really great. I think there is a lot of questions in the minds of people. People forever is asking, is this hereditary? Will my children get it? Why don't we know anybody who has MS? But I got it. And in the Black population, the questions are burning because of the lack of experience of this disease. So thank you very much. Your talk was extremely interesting. I think we can now move over to some questions, Kelly.
So there have been a few that have come in. Helen, one for you. I've been thinking of donating my body to medical research after I die to assist in MS research. How do I go about that? Helen, do you know?
I don't actually know, I'm afraid.
Can answer that question.
Okay, go on.
There's no reason why you can't donate your body, because bodies are used in various different ways and in all kinds of wonderful ways. So it's always a good thing to donate your body, because research is always ongoing on all levels, whether you've got MS or not. Doctor?
I would agree. But before you donate your body for research, if you're able to, and donate for organ transplant, if you're in a healthy state, that is vitally more important.
Yes.
Absolutely. South Africa's, I mean, the irony of the fact that we have had the first heart transplant, we are now the lowest organ donation country in the world.
Yeah.
Absolutely shocking. We need 4,300 odd transplants a year, and we don't even achieve a percentage of that. So please, yeah, if, you know, it's also important, there is actually, we've done another webinar, and I'll ask Non to share the link, on the consenting around organ donations, because it's important to know Simply applying to the Organ Donation Foundation and having the sticker in your passport actually doesn't grant you the opportunity to be able to donate your organs. That decision ultimately comes to your family in those final moments. So it's critically important that you have signed either a living will, etc., with your doctor, and you have it legally consented, so that you still have the ability to make that decision in those final moments. Because yeah, I think that there is this perception that if you've signed up on the ODF, the Organ Donation Foundation, etc., that is where the process ends, but it unfortunately isn't. So I will share that link. Nan can share that YouTube link, and you can watch all that info. And there was another question that had popped up regarding pregnancy as well. We did a webinar a few months ago on family planning with MS, and I will ask Nan to circulate that link as well. That might be relative to some people. Okay, so Helen, is MS environmentally influenced?
Yeah, so there does seem to be, from the literature, there is a lot of environmental influences as well as lifestyle influences. With regards to lifestyle, we're talking about things like smoking and so on. There doesn't seem to be any direct causal link that they've been able to show, but there does seem to be some connection there. So it's one of those diseases where there's a lot of genetics involved and a lot of environmental and lifestyle factors, but putting it all together, yet they haven't joined the dots. It's a lot of work in progress. So yes, but specifically, it's impossible to say.
Dr. Opperman, anything to add? No. Okay. I'm not sure. Have you got something to add with regards to that question?
Myself, it's very complicated. There are certain areas in the world that they seem to be a higher incidence, whether that's purely genetic or environmental is hard to say. There seem to be areas where there's less of an issue. There is that old adage that if you emigrate from a high area to a low area before the age of 12, that you assume the incidence of the new area. So there's certainly a combination. I think very much like Parkinson's disease, we have a disease where we have a strong genetic influence, but I think the environmental switch on is the most important answer at the end of the day. What switches it on?
Just to add something to that, if I may, they've actually found that in African Americans and in the States, can you hear me?
Yes.
Okay, in the States, where there's a higher prevalence of MS, in African Americans, there's a it's a higher prevalence rate in Black Americans than in Africa and in South Africa, which is very interesting, but it's still lower than in the white population. So, for example, as Dion was saying, Dr. Opperman was saying, if, for example, a Black South African was to move to the States, it may be that they would then assume, or that the prevalence would increase of MS for that subpopulation that had moved there, and because of the environmental impacts. So it's very much interwoven, and it's very complicated, the interaction between genetics and environment.
Okay, there is a burning question. Can MS affect your breathing, i.e. feeling as though you're not getting deep enough breaths?
Maybe I should take that one.
Yeah.
I think that the most common thing is the MS hug that we all know about. It's generally a spinal cord lesion. It's a demyelination of the spinal cord. It gives you a feeling of a tight corset, often around the chest, sometimes around the abdomen, but very commonly around the chest, and you feel like you can't breathe. The second thing is the anxiety sometimes associated with it, the panic situation, particularly a new lesion. It would be rare for someone who's very mobile and still up and going to have restricted breathing. Someone who has long-standing MS that is very disabled, they certainly might be breathing issues. There are rare complications. There's something called Ondine's curse. I leave that up to you to Google and look for. It's a very rare cause of MS where you have a lesion in the brainstem, but the most common feeling for MS patient breathe is a lesion in the spinal cord with the MS hug, in my opinion.
Okay. Someone says that they've been told that they can't donate blood. Is it because they're on rebirth? We'll have to come back to you. Okay, I'll take that up.
I have no idea. I'd have to find out.
All right, I will contact the medical advisor from the relative company to find out if there is any evidence on that.
Thank you.
Dr. Opperman, have you had any patients on cladribine or alemtuzumab, and are you seeing any results?
Okay, so we've struggled. We've tried to get 3 patients onto cladribine, and we haven't been successful at this point. We are jumping through the hoops bit by bit. Alemtuzumab, strangely enough, alemtuzumab was an old drug that we had many years ago, and myself and Dr. van Kodder had a patient that we shared who went between Bloemfontein and Cape Town because he studied there, and we gave him alemtuzumab more than a decade ago, and it worked extremely well. Both these drugs will be available. The issue is going to be just to get them through the medical aids to cover them. Having said that, I think the prices are going to be less scary than what we think when we look at the cumulative prices of the other drugs. So hopefully we can start using them more. There certainly have been cladribine patients approved in South Africa at this point.
Okay, I think this is probably the second last question. I see we're over time. I'm excited to be able to ask questions, and I'm faced an MS thing.
Sorry.
Oh, sorry. Is
flushed face in an MS state.
Yeah, yeah.
So some of the drugs can give you a flushed face initially, particularly in the beginning, but it's not a standard MS symptom. There are lots of other reasons to have a flushed face. I would just check them out first.
Okay, and then I think lastly, Helen, this, I don't know, it's probably for both Dr. Malherbe and Dr. Opperman. We have just moved from South Africa to the UK. Does this mean that the environment could have an effect on the progression?
It's impossible to say. There could be environmental influences that may have switched on or speeded up the progression. It's really difficult to say. Dr. Opperman?
Look, the only thing I would say is all we know that we can do is make sure your vitamin D levels are adequate and that you don't start smoking. That's it. And if you're over 12, you're probably not going to change the environmental factors that we know of at this point.
There was a question earlier with regards to seeking. Obviously, we know that we need to continue, keeping compliant on our treatment regime during the COVID time. Would you push out going in for MRIs, etc.? So your pathology updates, MRIs, whatever might need to be done as part of your monitoring. Would you push that out during this time, or would you still suggest that patients do that?
I think, as I said, this is not a silly little illness. This is a serious we need to keep abreast of it. I'm for keeping regular follow-up, and I don't think delaying an MRI, which is relatively low risk. All the radiologists have strict protocols. You're not exposed to lots of people at radiology. The equipment's cleaned. I certainly think monitoring is important. We don't want to miss the boat. We have all these. I started in this business over 2 decades ago. MS was terrible. Patients would come in. We knew there was one interferon. Nobody could afford it. It was a horrible situation. We're not in that situation anymore. We can be proactive. Can't sit back now simply because there is another risk.
Yeah, absolutely. So I think just a little bit of advice from my side, anybody who needs to go in for something like an MRI or pathology, etc., call ahead and just determine what exactly the hospital that you normally go to's requirements are ahead of time so that you're not surprised on the day, because we do know that they have all implemented certain regulations and restrictions, etc. But every hospital is different. So definitely do your research and obviously be prepared ahead of the time. We also do know that there have been certain hospitals, if anything needs to happen, any sort of day procedures, etc., that you are needing to provide proof of a negative COVID swab. If you have that issue, please do get in touch with us, because we are actually arguing that quite excessively at the moment with a lot of people, because obviously we know that that comes at an additional cost to the patient, and we don't necessarily think it's fair to subject a patient to a swab unnecessarily unless there is some evidence that they might be impacted by COVID-19. So don't let that hold you back. Yeah, I mean, other than that, Nan, I'm going to hand over to you to close. I think it's been an absolutely great, informative session.
Yes, it was absolutely. Everything was covered. I think there's one question that I've seen come up that is a very general question. It always comes up in meetings, doctor. She's asking, my sister and I have been diagnosed with MS within a short period of one another, and what are the chances? Dr. Opperman?
Look, we can both give a bit of an answer here. I mean, I don't often see members of the same family, but I have a mother and daughter, I have twin sisters, I have members of family. So as we said earlier, there certainly is a genetic predisposition. In fact, one of the first MS patients I diagnosed in my training, we diagnosed her sister 6 months later, who was a twin. But it's complicated. I'll hand over to Helen to add.
Yeah, I would echo Dr. Opperman's remarks. It's definitely complicated, and the genetics component is highlighted in situations of consanguinity where you have, for example, close degree relatives marrying and having children together, for example, where there's a higher rate of children affected by MS. So we know that there's a genetic component, but it's so complicated with the interaction and the epigenetics, we just don't know exactly how. So it could well be that there is a genetic factor there.
Thank you. Thank you very much. Maybe I can just say that in our group of just under 600 people, all with MS in a closed group, to us, it's almost like a quick survey or a quick research project. When somebody asks a question and there are 600 people all living with a condition who can actually give first-hand account of what's happening in their families. So apart from, we must every now and then say, remember, we are not doctors, and keep it on, but it's unbelievable the amount of information that comes out when one question like this is posed, where you have in our group, there are twins, one with and one without MS, and there are 3 sisters with MS, and there are a father, daughter, and a son with MS in the States. It's unpredictable. So thank you for that. Kelly, I think we've done well.
Yes, thanks so much to everyone for joining. Thanks to our speakers for taking the time, really informative. If there are any questions that come through after this, I will be sure to move them forward and send them along. Yes, I think also just this is probably Dr. Malherbe's first, I think, formal webinar, as she's come on as our Director of Research, and we're very excited to have her. I think it's going to make a really big impact on the work that we do, because we finally got someone who looks at the data, which is fantastic. And yes, Dr. Opperman, thanks. You're always so enthusiastic. I know that your patients absolutely adore you. And we're grateful that you have taken the time to be here with us today. So thank you very much. And then lastly, to Nan, thanks for all your dedication. We joked the other day that we're in this for life. We have no chance of parole. We'll be doing this forever. But really, thanks so much. It's really nice to be able to work with organizations that are so passionate. So we appreciate everything you do on your side.
Thank you, Kelly. From my side, our MS side, we are extremely grateful for your contribution and you coming into our MS lives with unbelievable technology and a huge group and a very, very large voice. So thank you very much for your availability and doing this for us today. We're grateful. Thank you, Dr. Opperman. We're very proud to have had you. And Helen, it was wonderful to have had the first association with you in the webinar.
And then lastly, to the patients, happy MS Day, and we hope that you have a fantastic day forward, and that it's absolutely awesome, a little bit warmer, thank heaven. So let's hope we all have a great MS Day going forward. So thanks, guys.
Great MS Day, everybody.
Bye.
Bye, everyone.
All the best. Bye-bye.
Bye.